Okay, so actually let's go back a page. So dissecting aortic aneurysms. I think we went over these. That's all right. Most common aortic catastrophe, it's going to affect 3 times as many people as your aortic aneurysm. So you're going to have signs and symptoms such as syncope, passing out, absent, reduced pulses, unequal blood pressure readings, right side versus the left side. If you put it on, you do 2 different readings on each side of the arm. There's definitely going to be a tearing sensation that they'll feel. That's going to be the distincting factor between a lot of other conditions. There'll be flank pain, scapular pain under here, pain radiating into the legs as well. So you want to get this person to the hospital as quick as possible because they are losing blood. They're losing blood really fast. So you can see the different types of aneurysms. So we have the normal, that's what it's supposed to look like, your aorta over the heart. At the very bottom where it starts, the root. Then there's ascending just above the root, and then as it goes all the way through, that's fusiform. There's type A, and then there is type B, which is the different types of dissections. As you can see with type A, it's almost right at the head. No, what is it called? Ascending. So right at the ascending portion, and then could also be coming down the side. But then if it's just this, it's type B. So if it's both, it's still type A, but if it's just not where it begins at, then it's going to be type B. 12 lead interpretations, so you want to make sure that you are successful as far as reading your 12 leads. When you're looking at these, separate it into 4 sections, and these are colors I can see. Actually, this is confusing. So I don't know why, that looks like 2 of the same types of blue, but anyway. So if you're looking at your lateral leads, you're gonna have 4 different leads that read into that because it's all going around the heart. It's the circumflex of the heart. So you have your lateral V5, V6, V5, V6 right here. And then you have lateral 1 and AVL. Lead 1 is right across here, the top, and AVL is going in that direction. Yeah, so that takes all of these away. AVR just throw out. As far as your septal leads, V1 and V2. So right over the heart right here, V1, no wait, V1, V2. And that's gonna go to the center, your septal center. Inferior, we have 2, 3, and AVF. So AVF is straight down, AVF, 2, so this is lead 1, and then going down towards the center of AVF, lead 2, and then back up, lead 3. So 2, 3, and AVF is your inferior. Each of these leads is reading from looking up at the heart from the bottom. Best way to picture that. And then anterior. Anterior is directly in the front. Could be close to septal, but instead of septal, it is anterior. It's right over the heart. So we have V3, V4, right at the anterior of the heart. All right, I think I'm getting better at that. And that's gonna give you your left anterior descending. Inferior is right coronary artery, and left circumflex, that's easy. Left anterior descending, yeah. As far as myocardial infarctions go, 12 lead EKG is a great tool for determining STEMIs, but remember 50% of myocardial infarctions are STEMIs and 50% of MIs are non-STEMIs, so you're not necessarily going to see it on there, which is why we treat everyone with chest pain or pressure as if they're having a STEMI. It's always urgent, just in case. So remember to use your assessment and patient's clinical presentation to best guide you. You have different types of myocardial infarction. So you have subendocardial. This is when the MI extends partially through the thickness of the myocardium. So may or may not produce a pathological Q wave on future 12 leads. So you might not see that little Q before the QRS. Transmural, so this is when the MI extends completely through the thickness of the myocardium. It's going to leave a pathological Q wave on future 12 lead EKGs, so you will be able to see it. STEMI, what you're going to look for, you want 1 millimeter or more of ST segment elevation and 2 or more anatomical continuous numerically consecutive leads. So looking at these, and we see any continuous ones, we have, yep, these are all of the leads, and these are the different names. Let's see. So yeah, V1 and V2, those are connected, V2, V3, V3, V4, V4, V5. Okay, all right. I always thought it had to specifically be, okay, so it's almost like poker. Like you want a straight, right? You need like a jack, queen, and a king. But I mean, in this case, it would just be like a queen and a jack. So it doesn't matter if it's any of these combinations. I mean, it can be these combinations, but what I've just realized looking at this, as long as the two numbers come one after the other, it doesn't just have to be like 5 and 6. It could be V4 and V5. And as far as what I understood, everything from class, it had to be V5 and V6 or V3 and V4. I didn't know, just like how these colors are different, V4 and V5 could be its own infarction, but it could be. So it would be anterior lateral, and this would be septal anterior or inferior, or vice versa. I'm really glad I just saw that because that cleared up a lot of questions for me. So you have different names of myocardial infarction. So you have a ST segment elevation of 1 millimeter or more. If it's in your lead 1, AVL, V5, and V6, that would be lateral. And I'm starting to like understand this as I'm reading it. I'm starting to get it right now without even having to look at this. So lead 2, lead 3, lead AVF, I know those are all at the bottom, inferior, going to be the inferior of the heart. V1 and V2 could be anterior, could be septal, but I know V1 and V2 are septal. V3, V4, anterior. I'm ready to pass this test. Okay, names of myocardial infarction. V2, V3, anteroseptal. Yeah, so these are the combinations, just like I was saying before, where you almost have to splice the types of the names. The names are combinations. So anterior lateral, anterior septal, well, let's see, V1, V2 and V3 would be septal anterior. Actually, let's look at what it actually says. V2, V3. V2, V3 would be anteroseptal. And then V4, V5, anterolateral. Anterior, so I guess anterior, think of it alphabetically, it always comes first. V2, V3, V4, V5, extensive anterior wall myocardial infarction. So where's V2, V3, V4, and V5? V2 is here, V3 is here, V4 is here, and V5. So extensive anterior wall MI. I guess if it's all 4 of those. I don't know what happens if it's 3, but if it's all 4, it's extensive. All right, we have right-sided 12-lead EKGs. I need to turn the Apple News off. When an inferior wall MI is identified in the ST segment elevation, 2, 3, and ABF, you're going to complete a right-sided 12-lead EKG. So to do this, we're going to move V4 to the right side, the same anatomical position as normal 12-lead, just on the right side of the sternum instead, and attain another 12-lead. Cool. Complete right-sided 12-lead. So you're going to look at the whole side of the heart. We know that it's, I'm going to lose my battery. We know that it's at the inferior part, but we want to see if it's on the right side as well as the inferior. So instead of V4 being on the left side, we're going to move it to the right side to take a picture from that way to see if there's damage on the right side as well. Let's just stop before the battery dies.